So John's talk was a perfect prelude to mine, and what I'm going to talk about are sex differences in melanoma incidence and survival from the population sciences standpoint, including the epidemiology, prevention, and social demographic factors. I'm also going to conclude just a little bit with what might be sex differences in melanoma prevention. So how are we doing in terms of melanoma incidence? The number of new cases this year has been estimated to be over 73,000 invasive melanomas. Those are potentially fatal melanomas, more in men than in women. But we see melanoma now as about the 5th most common cancer in men and the 7th in women. However, it is not a leading cause of cancer death in either gender. Alarmingly, though, over the last 30 to 40 years, we've actually seen a dramatic increase in melanoma incidence in young women between the ages of 15 to 39. So the first study to show this showed that from 1973 to 2004, the incidence of melanoma more than doubled in this young adult female population. We believe this is a birth cohort effect for women born after 1965, and we don't see trends in changes in immune factors, host factors, genetic factors over such a short period of time, so we look for environmental factors. And the main environmental factor that changed over this time period was the use of tanning beds, which became prevalent particularly for young women in the 1980s and on. So this is just a schematic looking at the incidence of melanoma here between 1983 and 2007, women between the ages of 20 and 39 divided into various age groups. And over each of these various age periods, year periods rather, 83 to 87, 93 to 97, 2003 to 2007, the incidence of melanoma has continued to climb. In 2010, there were 4 hallmark studies around the world, including one case control study in Minnesota, which actually cemented the evidence linking indoor tanning to melanoma. Indoor tanning and UV light in general is considered a class 1 carcinogen in terms of its skin cancer risk. In the Minnesota case control study, it was shown that individuals who had ever used a tanning bed in their life had a 75% increased odds of getting melanoma compared to those who never used it. And that was true in both men and women. But the reality of tanning beds is we see their use predominantly in young women. It's been estimated through various reports in the morbidity and mortality reports for the CDC that about 25% of young women between the ages of 18 or maybe even 14 to 25 use tanning beds regularly, and those who use them at least once tend to use them more than 10 times per year. So if we now believe that each indoor tanning use raises the risk of melanoma by about 1.8%, you can see how this risk of melanoma is going up dramatically. And one of my colleagues at Brown University has called this an experiment on millions over the last 30 years that we're now seeing the results of. In 2011, California was wonderfully the first state in the nation to enact a tanning bed restriction for minors. So individuals under the age of 18 cannot use tanning beds. And this was followed by now 10 other states, you can see largely in the West, but then Texas, Louisiana, Minnesota, Illinois, Vermont, and Delaware is in there. And numerous states are trying to enact this same legislation, but it's a very difficult battle. The tanning bed industry is a $5 billion one, and the lobbyists fight strongly that the tanning beds are good for us. They give us vitamin D. There's a lot of inherent myths to that concept, since tanning beds emit mostly UVA, and we get our our vitamin D from UVB and so on. And what we did in conjunction with CPIC, which is a group of research epidemiologists that the Stanford Cancer Institute partners with. This is the Cancer Prevention Institute of California. And we've worked with this group for many years to establish trends in melanoma epidemiology, trends in various racial, ethnic, and sociodemographic groups. But given this early data showing the spike in melanoma incidence in young women, we took a look specifically at melanoma incidence in the state of California in young women according to socioeconomic status, because our CPIC colleagues actually have a validated measure of SES, and this helps us to really look at the interplay between environment and social status in various cancers. And what we found is the highest incidence, an 80% greater incidence in young white women, 15 to 39, in the highest SES brackets with the highest UVR, and we did not see this in young women who had the highest UVR and lower SES groups. So what this is suggesting that affluence-associated lifestyle behaviors, including indoor tanning or recreational tanning, could have a bigger impact on melanoma risk than sun exposure alone. And this type of data was actually quite useful for California to enact the ban in 2011. Colleagues of mine at NYU have come up with, I think it's a very cute paper, and it makes a lot of sense intuitively, but somebody actually did it, and they looked at the change in clothing coverage in recreational and swimwear in both men and women over the last century, and correlated this with melanoma incidence via the SEER statistics, which go back in Connecticut at least to 1950 and on, and then in the SEER registries nationwide from the 70s and on. And you can see how the clothing here is becoming less and less covering, I guess is the way to put it, and even more so with Sean Connery here at the bottom. And we've seen all smaller, it's a dated picture. So certainly this study is very nice. It's in the American Journal of Public Health. And what it's shown is that there is a true parallel between the clothing becoming less and less in terms of its coverage, and then we're seeing these incidence increases in both men and women in melanoma and other skin cancers, but melanoma in particular, which is tracked several decades later because of the lag time we see with sun exposure and cancer development. So we know that we want to reduce our excessive sun exposure. This is the main risk factor that we think of for melanoma in white skin populations worldwide. We know that we get most of our sun exposure in early childhood, although there is a chronic amount of sun exposure that occurs over life. But can we prevent melanoma through sunscreen alone? Well, recently we now have the first sunscreen randomized controlled trial that was conducted in Australia, and data that has shown that it has reduced melanoma risk. So this was the NAMBOR skin cancer prevention trial. They looked at 1,600 plus adults, aged 25 to 75, divided them into half using SPF 16, which is quite low, sunscreen to the head and arms only, the other half using it on a discretionary or optional basis for about a 4.5-year period, and then 10 years later, looking at the populations who had used or not used sunscreen, and saw about a 50% reduction overall in melanoma risk. And so that's remarkable, and it was true for all sites of the body, suggesting that the users of sunscreen tended to be more self-aware and probably applied it to other sites of the body. Key points from this, again, are a very low SPF sunscreen that isn't broad spectrum compared to the superior sunscreens we have today, and not extending the study to younger age individuals who might have a better result if we were to actually use this kind of protection consistently in children and adolescents. So it's very encouraging data that sun protection can prevent melanoma. It's the only randomized trial we have in the world about this. Now, what about melanoma mortality? Melanoma mortality, we see about 10,000 cases that are anticipated, individuals who are anticipated to die from melanoma this year, 2/3 of whom will be men compared to women. I'm going to focus on that. We've seen some reductions in mortality or plateauing in younger age groups in both men and women. We can't yet say this is because of our early detection strategies or our primary prevention strategies. But what's critical is that early detection really is the vast way to reduce deaths from disease. And this graph is just looking, this is the American Joint Committee on Cancer, 20-year survival rates for their large worldwide database. This will be updated soon with the newest iteration of AJCC cancer staging coming out in the next couple of years. But you can see patients who have thin melanoma, stage 1, which is our thinnest type of invasive melanoma, at the time of diagnosis tend to do quite well. We've now been able to push this level, the tail of the curve, the survival statistics for patients with stage 4 advanced melanoma up through newer immuno and targeted therapies. But clearly, if we're to diagnose more patients in their thin early phases, we're going to save more lives. So it's been said that melanoma writes its message in the skin with its own ink and for all of us to see. So why is early detection of what is largely a visible skin cancer so difficult? A couple of key points have to be tied into mortality reduction, and this requires an understanding of the tumor biology. Are there subtypes of melanomas that behave in different ways in terms of their prognosis? The epidemiology, who gets the disease and who passes away or lives from it. The sociology of the disease, who is going to practice certain behaviors that will enhance or impede early detection strategies, prevention, and treatment. We know that physicians find thinner melanomas than patients do. It's critical to have an opportunistic screen for melanoma. In other words, when a patient comes to me or a primary care colleague with a bleeding lesion on their body and says, I'm worried about this mole, it's been changing, invariably that's going to be a deeper, less curable melanoma than when this is picked up in an opportunistic fashion during a routine primary care physician screen. And so we're really trying to enhance skin cancer education and triage in primary care providers as a whole. We also know that individuals, again, of lower socioeconomic status, as well as middle-aged and older men, suffer the most disproportionate deaths from disease. And this is just a classic chart now that's now true essentially worldwide, where we've seen melanoma mortality rates, the death rates from melanoma rising 157% in white men over the age of 65 compared to middle-aged men who still have higher rates, but compared to younger individuals and women overall. In 2003, the American Association of Cancer Research Cancer Progress Report showed that melanoma here was one of only 3 cancers where the death rates in men were rising between 1990 and 2009. They're falling in all other cancers. So we clearly have an indication to target middle-aged and older men for early detection strategies in melanoma. They account for about 60% of all melanoma deaths in the US, and men, from a behavioral standpoint, are less likely to navigate the healthcare system as effectively as women. So they are less likely to participate in cancer prevention, have a routine healthcare provider, et cetera. Several years ago at Stanford, we actually conducted a study looking at newly diagnosed middle-aged and older men with cutaneous melanoma, and to try to determine what factors in the tumor, what factors in their lives, their behaviors, their health practices were related to thinner versus thicker tumors at diagnosis. And we found those thinner, more curable tumors are again related to physician detection, so again, that opportunistic detection by their doctor, having higher education, which equates to higher awareness, and then having a certain type of melanoma that's not related to what we call a nodular subtype, which I'll show a picture of. We also found that the role of the female spouse or partner in this elderly male cohort was critical to getting the patient into the doctor, advocating for skin examinations, et cetera. This is a picture of nodular melanoma. Nodular melanoma tends to elevate, ulcerate, and bleed. It often doesn't have the ABCD criteria we talk about for other cutaneous melanoma subtypes with asymmetry, border irregularity, color change, et cetera. The darkening you see here is from dried blood. So I like to look under every Band-Aid I see. Patient says, I've had a bug bite, it won't go away. I have a pimple, it won't go away. Nodular melanoma is a tough one, and it's often not even pigmented. The problem with nodular melanoma is it accounts for a small percent of the melanomas we see overall, but significant proportions of the thick melanomas that are less curable, and in a recent mortality analysis actually accounted for up to 40% of fatal melanomas, even though it was only 14% of the overall subtypes. This grows rapidly. It's difficult to detect. We see it more in men. We see it more on the back in men. And so this has been a really tough challenge in terms of trying to enhance early detection. As a result of our study that we conducted several years ago, we came up with a novel educational campaign directed to middle-aged and older men in particular. We entitled it Watch Your Back. And the reason for that is that about a third of melanomas in men occur on the back, and as I alluded to, they tend to be more aggressive types, in part because of probably delay in just diagnosis, not recognizing they're there. This incorporated the aspects of the study to involve the spouse or partner in getting the patient into the doctor, to ask and advocate for a skin exam during routine physical examinations by that provider, as well as to simply look at the back. If we could reduce thick melanomas in men on the back, we'd go a long way to reducing mortality. The concept that melanoma behaves in a less malignant fashion was first proposed in 1969 by Dr. Wallace Clark, who was one of the melanoma pioneers in the field, a pathologist. And we have attributed this in the older age patients largely to differences in behavior, detection, potential diagnostic delays in screening, those health practices that I talked about. But since about 2011, there have been 3 papers that actually suggested that there may be a biologic gender difference, not just behaviorally driven. And these came out of Europe, the Munich and Dutch cancer registries. And the third paper, perhaps the most compelling, came out of the EORTC data. That's the Cooperative Oncology Group data in multiple countries in Europe. These studies showed a consistent 30% overall survival advantage in women compared to men. They showed this is to be true whether women had lymph node or distant metastasis. And in the EORTC trial, these are patients who are going on melanoma oncology trials who have the same access to physicians, provider care, to surveillance, to studies, and to treatment. And so this was true in these studies regardless of the thickness and the anatomic site, and sometimes they looked at subtype. But this, again, was a largely older population because we see most patients with melanoma diagnosed around the age of 59 or so. So as John alluded to, what we elected to do with our CPIC colleagues and published about 2 years ago was a study looking at adolescent and young adults, both men and women aged 15 to 39. We think that this population is sort of less prone to have those behavioral differences in screening because it's a largely healthy population. So we looked at data in the SEER registry from 1989 to 2009. This gave us over 10 years of follow-up, a mean of 7.5 years. We have to focus on non-Hispanic whites because they account for over 95% of the melanoma cases we see in the national database, the SEER database. This has been a criticism of the study. We do have a burgeoning population of Hispanic patients with melanoma, but the numbers are small, so it's difficult to find trends. We looked at melanoma-specific mortality, so deaths from melanoma specifically, and found over 26,000 invasive melanomas with about 1,500 deaths. Now, not surprisingly, men accounted for 40% of the overall melanoma cases, but 64% of melanoma-specific deaths. So men did worse than women on an overall basis. But when we adjusted this for specific age ranges under age 39 and other primary cancers, the location of the melanoma in the body, the tumor thickness, that's the hallmark of how patients do, whether the patient had regional lymph node metastasis or just had skin melanoma, and the histologic subtype, including whether they had nodular or superficial spreading melanoma, we found again that young men were 55% more likely to die than young age-matched women. And this was also alarming. We looked at traditional sites where women do worse. Dr. Dan Kapp brought this up. Anatomic location on the leg is traditionally associated with a good prognosis. We see those more in women. But even in this study, location on the leg in a man was more likely to cause death, about 67%. The histologic subtype, I said there were no differences. And then again, if someone had skin-only melanoma, the males were 52% more likely to die. If they had disease in the lymph nodes, males 74% more likely to die. So very alarming data. And this really brought forth the question of whether there's a protective factor in women versus a stimulating factor in men. And there's been multiple theories for the survival disparity. The most obvious or intuitive would seem to be differences in sex hormones. But estrogens have been looked at both in melanoma treatment, estrogen receptors on cells. We know that melanoma cell lines express estrogen receptor beta, but it does tend to be equally distributed among men and women. We've looked at somatic mutation changes, the mutations we're now using to target therapy with KIT, BRAF, and NRAS mutations, and they appear to be equally distributed among the sexes. The androgens are an interesting concept. There was a study that came out, again, a large epidemiologic study looking at the cohort of men with prostate cancer who were followed over time in a large health professional study in men, and found that they had about an 83% increase chance of getting melanoma, and they looked at other non-melanoma skin cancers, which are also sun-related because you're looking at an older male population, so you have to wonder if it's just a sun issue. But maybe there's a role for androgens, and that's one thing that we'll be also exploring in our study with Dr. Sun Wu. The immune homeostasis and regulation, I think, is incredibly compelling in terms of immune responses. We see women in general have a more robust immune response, as John mentioned, more autoimmune diseases. We see more conditions like dermatomyositis and lupus in women. We see more organ transplant-associated graft rejection in women. So there may be a more robust immune system, and again, the biology of this is critical to find out. There may even be differences in the way that the various sexes respond to UV-induced radiation mutations as well as exposure patterns. So we're really working to find this out. I just wanted to throw in a few slides of what might be a true sex difference in melanoma prevention strategies. And chemoprevention is where we're going to take a very safe medication, like a nonsteroidal anti-inflammatory agent such as aspirin or ibuprofen, a vitamin D, a vitamin, or a supplement that's available and safe and well tolerated, and try to give it to patients who are at high risk for a cancer and prevent it at the outset. Melanoma has been an ideal cancer to study in this regard, particularly in young patients who represent the second largest loss in productive life years of all solid tumors when they succumb to melanoma. And melanoma is also related with a phenotype that we see called clinical atypical nevi, or the atypical nevus syndrome or phenotype. And these patients have a significant risk for melanoma, while individual nevi tend to not transform into melanoma as much. These nevi act as a significant risk marker for getting melanoma. So we actually have conducted a phase 2 study of a nonsteroidal anti-inflammatory agent called Sulindac in patients with that atypical nevus pattern to prove that an oral agent could get to the target tissue, namely a nevus. And we're moving forward with the nonsteroidal anti-inflammatory agents in other avenues as well. Nonsteroidal anti-inflammatory agents, they will block inflammation via inhibition of prostaglandin synthesis, but there are other pathways in melanoma cell lines that may be very relevant for control of cancer. And we then conducted, based on data that had been published, I should go back one slide here, both clinical and epidemiologic studies, which have shown some lower melanoma risk in individuals who've been exposed to nonsteroidals, namely aspirin, over time. And this has been an unclear association, but multiple studies have suggested an association. So along with Marcia Stefanik and Jean Tang, my colleague in dermatology, and others, we have looked at this very rich data source, the Women's Health Initiative, the observational cohort, to look to see whether drug exposure to nonsteroidal anti-inflammatory agents was associated with a lower risk of melanoma. And we had, again, based this on some of the cohort studies that have shown a potential protective effect of nonsteroidals in women exposed to continuous low-dose aspirin. Those studies were out of Europe. And then a Harvard case control study which showed about a 50% reduction in melanoma risk, particularly following aspirin exposure for over 5 years, with a trend toward this response in women over men. So we were able to look at cutaneous melanoma in the observational cohort of the WHI data set. This is about a 60,000 population we were able to look at in women postmenopausal ages 50 to 79. I think I'm saying that right. 50 to 75, Marsha, or 50 to 79? Thank you. And because these women are followed long-term with multiple questionnaires on an annual basis, serum and blood draws, medication history called over time, looking for changes in risk factors that could result in cancer development, the melanomas were actually tracked and followed over many, many years. We were able to adjust for important risk factors for melanoma, including sun exposure, childhood and current. We were able to adjust for sunscreen use and many other factors that are relevant. And this is just some of the medications used 2 times per week in the last 2 weeks was one of the questions. If patients said yes to this, the strength, the duration, and the dosing were obtained, not the number of pills. The prescription record was validated and or bottles collected. These patients were asked and queried over many years as to the medication use. And what we found were 548 melanomas, about half in situ, half invasive. Baseline aspirin use was evident in about 25% of women, most of that being regular or extra strength aspirin, so only 25% of the population used baby aspirin or low-dose aspirin. There were similar ages, history of skin cancer, sun exposure, and history of melanoma in the groups with and without the aspirin exposure, but women who used aspirin had a 21% lower risk of melanoma. And when we looked at the P trend over time, longer use was associated with about a 30% reduction in melanoma risk in this cohort. We did not see this in women who were on the non-aspirin nonsteroidals like ibuprofen, naproxen, but in essence, these patients were much fewer. There are fewer individuals taking those drugs long-term compared to aspirin. So this is an important association. It's not a clinical trial. We are not telling older women to take aspirin or ibuprofen to prevent melanoma. We don't know what kind of dose may be effective, but this is, I think, in support of the prior case control studies and European data which have really suggested that women may be benefiting from this. It's not to say men don't, but we have more data in support of women. Finally, just my last slide, just to look at chemoprevention of melanoma. Again, I think this is as important as the research we're doing on immunotherapies and targeted therapies for advanced disease, where we could prevent melanoma in high-risk cohorts at the outset. Thank you.